Very good. Last hour. Okay, so the final topic. We only have 47 slides, which is about, well, it's not many slides compared to what I would usually give in a 2-hour lecture. So I think we're going to be bang on 1 hour, which is good. We're going to be talking about kinetics and pharmacodynamics. Getting my watch out so I know how long I actually speak for. So, pharmacodynamics versus pharmacokinetics. Pharmacodynamics is the study of the biochemical and physiological effects of a drug on a living thing. So that could be humans, that could be microorganisms, could be horses. It really depends on, what the sample has come from, why you're analyzing it. There's all different types of things. So we talked about, doping in horse racing, for example. Good example whereby you're going to get samples and you're going to want to know what drugs do on a horse. So the two names, pharmacodynamics and pharmacokinetics, they are annoyingly similar and easily to confuse one another. So pharmacodynamics is how a drug affects an organism, whereas pharmacokinetics is the study of how an organism affects a drug. So if you're looking at, say, how a drug is metabolized in the body, that's a study of how the organism has affected the drug, so that's pharmacokinetics. If you're looking at whether or not a drug makes a person sleepy, that's an effect on the organism, so that would be an example of pharmacodynamics. So pharmacodynamics is quite a lot of things, like looking at how drugs bind a receptor and what then happens within the body based on that binding event. So it's also quite interested in how the effects occur. So drug effects, to elicit a physiological effect, there needs to be some sort of interaction between a target molecule and a receptor protein. Now, before, when we were focusing on pharmacokinetics, how an organism affects a drug, we were very much focused on the liver, I would say, because metabolism is based in the liver. The liver is where you get all of these chemical transformations, phase 1, phase 2 metabolism taking place. Now, pharmacodynamics, what a drug does to an organism, this is going to be based more in the brain. So we're looking at the place where the receptors are based, and literally it's everywhere. But if we're going to be talking about illicit drugs, we're very often focused on the receptors in the brain. So the ones that trigger, a high, tranquilizers, uppers, downers, all of these are based, in the brain. So receptor proteins initiate the process of signal transduction. So what actually happens is your drug, let's keep with our illicit drugs in the brain example, the drug makes it through the blood-brain barrier, travels around, it finds a cell, a neuron cell in your brain, and it's going to reach the outer cell wall of that neuron. Now, at that point, there's going to be some sort of receptor based there, because typically the drug doesn't have to migrate inside the cell. It could be just a case of it has to find the outer wall and bind onto a receptor. There are proteins embedded in the cell wall so that if something happens on the outside, there is a chemical transformation that then occurs on the inside of the cell, and that is called signal transduction. It's kind of like a chain of dominoes. So we have our drug, it hits the first domino on the outside of the cell wall, that domino falls over, something happens on the inside of the cell, so that's a domino hitting another domino, and then, chemical transformations take place, who knows, something gets triggered inside the cell wall, so more dominoes are falling down. This process of, a chain reaction of different events, starting with a drug, moving through, cellular machinery, this is called signal transduction. It's the movement of a signal from your illicit drug to something occurring physiologically in the cell. Now, these physiological effects in the cell, you can nearly relate this in terms of like a broader organism and talk about the effects like the therapeutic effects. So let's say we have a painkiller. You take a painkiller, your pain is killed. That is the therapeutic effect. It's the effect that you wanted to happen when you took the drug. You took the drug and that effect happened. That was the therapeutic effect. Then there are side effects. So, I don't know, you take a drug for your pain is killed, but you also get constipated. Classic example for opiates. yeah, you took the drug, your pain was eased, so that was the therapeutic effect, but you also got constipated. That's the side effect of the drug. There are also toxic effects. So, you take a much too large amount of opioids and it causes liver damage. That would be a toxic effect of taking that drug. So yeah, back to the therapeutic effects, that's the desired effect that you have. And depending on what the effect you want, the therapeutic effect can change and swap with the side effect. So for example, for a narcotic, for pain relief, that's the therapeutic effect. Side effect is that you experience drowsiness. So, don't take this drug and then drive because you're going to feel drowsy. So pain relief, therapeutic effect. Side effect, drowsiness. Toxic effect would be when you exceed the dose, and then you might get tinnitus, which is a ringing in your ears. It's another good example of not a side effect, nearly went wrong, a toxic effect that can occur from exceeding the safe level of the drug in terms of dosage. So something to consider, therapeutic effects and side effects depend on what the drug is prescribed for. So back to our opioid example, the therapeutic effect might be pain relief, that's what it's prescribed for, and the side effect is constipation. However, if you are experiencing diarrhea, you might be prescribed an opioid. Then the therapeutic effect is the constipation. It's going to stop your diarrhea. The side effect, though, is now pain relief. So the idea of a therapeutic effect and a side effect, it really depends on what you want from the drug. And remember that drugs can do multiple things. Appetite suppressant and, the high that you get from tetrahydrocannabinol. Well, THC is now used in a medicinal sense. So, that there are going to be therapeutic effects, there are going to be side effects. If you are, smoking cannabis to suppress your appetite to lose weight, then the therapeutic effect is going to be, actually, no, the other way around. You get the munchies from THC, don't you? If you are smoking cannabis to put on weight, well, that would be the therapeutic effect and the side effect would be getting high. Right, so therapeutics versus poisons. The dose maketh the poison. Essentially what that means is everything out there is a poison. You just need to take enough of it. If you take the most benign drug and you exceed the therapeutic dosage or the recommended dosage by an order of 10, a factor of 10, that overdose is, the equivalent of a poison anyway. So if we have a look, this is basically, here we have the effect, here we have the dosage. So there is an amount of drug below the therapeutic effect. So let's say you have a really, really bad headache and you want to take aspirin. If you take 1 milligram of aspirin, that's probably not enough aspirin to do anything for the pain that you're feeling. So that would be below the therapeutic effect. But then we get the correct sort of dosage, like take 1 or 2 tablets of aspirin, and then we're in the realms of you will get, headache suppression and you won't experience any negative effects. If you take 10 aspirins, well, you're going to start seeing toxic effects, whereby your liver might start to get damaged if you regularly take way too much painkillers. If you take 100 aspirin, well, at that point, the level or the concentration of the aspirin in your system is going to be so high that it's going to interfere with the regular cellular workings in your body, and it's probably going to overwhelm your organs, at which case they shut down and you die. So what is an effective dose of a drug? Well, it depends. The route of administration influences the magnitude and specificity of the response elicited. So the classic example is if you inject a drug, you are going to vastly increase the magnitude and potentially the specificity of that drug. If you take the same drug orally, well, then you have the delay. You need to get crossing the membrane absorption to occur, and it's probably going to occur over a longer period, because we were talking earlier about enterohepatic circulation and the fact that you get metabolism, the body tries to get rid of the drug, puts it back into the gastrointestinal tract, but then the bacteria eats the sugar, the water solubilizing groups, gets reabsorbed, and then it potentially gets put back into the circulatory system. So we have this extension, a delay to get the drug into the body, and also sort of a redosing effect as the drug gets reabsorbed from whatever excretory pathway it might be traveling through. Now, just to complicate things further, individuals can respond differently. So while I would say that most people have the same receptors present, like through evolution, it's not like we all have dramatically different chemical or drug receptors in our brains, but the actual numbers of the receptors and where they're placed can be different. So a good example would be the receptors in our brain for alcohol. So there's the classic, I guess, stereotype whereby people of Asian descent, they don't need very much alcohol to get to that, red-faced jolly situation. Whereas us of Western, descendants from England, basically people in England for like hundreds of years, like you couldn't drink the water, it was unsafe. So the safest thing to do was to simply drink alcohol constantly, like really, really mild beer. That's all anyone drank. And that has had an evolutionary effect whereby, basically our tolerance as people descendant from England is greatly higher than other places in the world. Where cultures where that has not happened, well, in that case, they will have different tolerances through, natural selection over multiple generations. But yeah, anyway, generally people will have the same sort of receptors, the same types of enzymes in your liver, but the number and distribution might change from person to person. Right, so the FDA, the Federal Drug Association, I think, as I think off the top of my head anyway, the American association that oversees, the way that drugs, making them safe, all that sort of stuff, they need drug makers to show that a drug is effective and that it's safe. So you're not allowed to, sell drugs that don't work, and you also need to provide instructions that allow the drugs to be taken safely. Now, the FDA rules, they're kind of interesting. So depending on what your drug is for will depend on how stringent those rules will be. So for example, let's say you are bringing a new chemotherapy reagent onto the market. Well, you don't need to show that your chemotherapy reagent is 100% safe because it's basically cellular poison designed to kill cancer. It's always going to have a lot of toxic effects associated with it. So because it is a drug designed to treat such a serious illness and not having the drug at all would be catastrophically bad, the fact that it has a lot of side effects and is quite bad for you, it's ignored. Whereas if you're bringing the next, headache tablet onto the market, you need to show that it's 100% safe and it needs to have a level of tolerance so that it's not easily overdosed on. So, there is that level of changeability, I guess, or flexibility in the rules, but yeah. So, dose response studies. This is how the FDA requirements are typically investigated. They will, if we go back, if we have a look at this, they are going to give people multiple doses, starting here up to the therapeutic dose, hopefully avoiding this zone. So obviously, whenever they're doing these sort of experiments, we're starting with animals. And the idea of the animal studies is we want to know this sort of region here. We want to know the therapeutic effect, but we also want to start to see where the toxic effect kicks in. This allows us to gauge a safety margin. So we're like, okay, therapeutic effect starts here, starting to see toxic effects here. Maybe we'll select our dosage level from here to here when we get to the human volunteer study. And the human volunteer study will probably start here and go up to here. So we'll have some people getting effectively a placebo or no drug at all. We'll have some getting a low level and we'll investigate whether they see any effects at all. And then we'll give people a low therapeutic effect level. We are avoiding trying to, have anyone getting toxic effects, and we certainly don't want anyone having a lethal effect in our drug trials. Yeah. So often there is a threshold dose that must be met before any effect is seen. So here, this is our threshold dose. Anything below this line, you're not going to notice any positive effect at all. So effective dose versus lethal dose. There are two values that are typically investigated, hopefully using animal models. The ED50, which is the dose at which 50% of the population experiences the desired therapeutic effect. So half don't see an effect, half do see an effect. And then there is the LD50, and that's the dose at which half your population dies. So obviously this is the log dose. So, factor, we're not talking about linear increase. We're talking about an exponential increase in dosage. And obviously this is 0 dose. We're increasing the dose, increasing the dose, increasing the dose. We reach this point where we have 50% of the test subjects having the desired effect. Increasing the dose, increasing the dose. This is the first dosage whereby we saw any lethality at all. Increasing the dose, increasing the dose, increasing the dose, then we get the LD50. You would not exceed the experiment. We do not need to figure out the LD100, where we absolutely euthanize every single animal in the study. Ethics would not approve that, but we do kind of need to know the LD50. This is quite important, especially for drugs designed to be used as medicines. So, therapeutic index, which you may have heard of, this is simply defined simply as the LD50 divided by the ED50. So 50% lethality divided by 50% effective dosage. And when you divide these numbers of dosage by each other, you're going to get a number, a unitless number. And this is the number that we gauge the safety of our drug candidate. Now, there is an alternate measure. There is the LD1 divided by the ED99. So the LD1 in this case will be down here. We need to kind of imagine that this red line is further in this direction because the ED99 would be up here. And we kind of hope that this will be down this way to allow us to divide the numbers together. Now, this would not be a particularly safe drug. Like, you look at it. We do not want our drug to look like this because it means that, let's say we absolutely can't take the drug if anyone's going to die, for starters. So let's backtrack to here, round about here. This means that at the maximum dosage that we don't kill anyone, only about 60 people are going to get the effective dose. So it will only have a notable positive effect for about 60% of the people you prescribe it to at the point whereby people start to die if you exceed that dosage. And I mean, back to chemotherapy, if this is for a chemotherapy drug, fine, that's probably okay. We're going to dose them below the point where people start dying, but maybe it only works 25% of the time at that dosage. That's still better than everyone dying of cancer if you save 25% of people. But for something like a headache pill, obviously it's not going to look like this. This effective dose would be way down here, and we'd be applying a dosage down here, far away from the lethal and hopefully also the toxic effects. So, alternate measure of the drug is the LD1, where 1% of the population dies, divided by the ED99, whereby 99% of the population got the positive effect that you were hoping to get out of it. So here's an example. We have the ED50 of fentanyl is 100 micrograms. Compare that to the ED50 of morphine, which is 10 milligrams, okay? So what's that? That's 0.1 microgram for fentanyl, or 0.1 milligram for fentanyl and 10 milligrams for morphine. So morphine is like 100 times better, or safer, I should say, than I should be talking about the LD50, I guess. So I guess the effective dose. Okay, the effective dose from fentanyl, it is, so 1.1. So yeah, it's 100 times more effective. So you need a dosage 100 times lower to get the same effective dose for fentanyl. But then we have a look at the LD50, and again, 70 milligrams is where you kill half your population, whereas only 300 micrograms will kill half your population for fentanyl. And this is graphed up here, so have a look at that. The ED50 and the ED50. So yeah, based on this, considering you get 50% effectiveness with 100 milligrams, but if you go to 300 milligrams, you're killing half your people. Compare that to morphine, 10 milligrams, but then you have to increase up to 70 to kill half your population. So morphine is just a lot safer because of the distance between these two. Like 60 milligrams is a huge difference, whereas 200 micrograms is an incredibly narrow difference in dosage to go from it works to you're dead. So here's just an example. So based on this one, so, you know, same numbers. LD50 is 70 milligrams. ED50 is 10 milligrams. Here we have fentanyl 300 micrograms to 100 micrograms. Therapeutic index, I've just taken off the units because the units get cancelled out anyway, so it doesn't really matter as long as they're the same between the two. Obviously, if the LD50 was in milligrams and the ED50 was in micrograms, you would have to do a conversion to make the units the same. But we do our 70 divided by 10 gives you a therapeutic index of 7. For fentanyl, 300 divided by 100 gives you a 3. The bigger the number, the safer the drug is. So therapeutic index for morphine is 7. It is a bigger number than fentanyl, so morphine is safer than fentanyl. So this is, you know, doctors will be making these sorts of calculations, and this factors into their decision as to what, so it should factor into their decision in terms of what drugs they are prescribing. Because it's not like there's like one drug that, you know, is used to treat a condition. There's generally a whole bunch of different drugs that claim to do the same thing. Some will have different effectiveness, obviously. Some will have more toxicity. So the way around it is you can, you know, do this therapeutic index, look at its effectiveness, look at its toxicity, get a number, and then you can just rank the drugs and go, okay, what's the safest one? Morphine's the safest one. Give me morphine then. Don't want the fentanyl. Okay, so a margin of safety. So here we have two drugs. Drug A, shown here in the turquoise, I think, and drug B, shown here in the red. And here is both A and B together. Right, so the effectiveness of the drug is the blue one, and they both have the same effectiveness. A and B is the same. There is, however, a difference in their lethality. So as we can see from the red one, we very quickly get some lethality. So, you know, we're killing people already down at 10 to the minus 3 milligrams per kilo, which is very, very low. Whereas if we look at the other drug, we're basically up to 10 grams before we start to kill anyone down here. Oh, actually, no, 10 milligrams. I tell a lie. Yeah, so the interesting thing about this one is if you are considering the LD50 for these two profiles, actually drug A and drug B have the same LD50. But the point is that drug B, at very, very low concentrations, you start to get a low number of fatalities, whereas you don't see that for drug A. So the point of this one is if you use the ED50 divided by LD50, both of these will perform exactly the same as one another. Because their ED50 is the same, their LD50 is the same, it's the same numbers, you would wind up with the conclusion that both of the drugs are equally safe or equally unsafe. However, if you use the LD1 divided by the ED99, while the ED99 is the same for both, so you know, it's the same profile, but all of a sudden the LD1, this one is way, way, way smaller compared to the other one. So if we plug those in, we quickly see that drug A has a therapeutic index of 1. Drug B has a therapeutic index of 0.0002, which is extremely small compared to drug A. So drug A is much, much safer than drug B if you use the LD1 divided by the ED99, as you should, whereas if you're using the LD50 divided by the ED50, in that case, there is no difference between the two drugs, even though there obviously is in terms of deaths from drug B. So, target molecules. Given the number of molecules within the human body, the drugs must be targeted. I mean, I have no idea how many molecules there are within the human body, but it would be trillions, billions, zillions. I'm not sure. It's been a while since I've, pondered Avogadro's constant of like the number of atoms in like a couple of grams of material, but we know it's a stupidly large number. So what that means is that your drug needs to be targeting a specific receptor. And that's what receptor theory is all about. A specific drug is going to interact with a very small number of molecules, target molecules. So a receptor is simply a target molecule that your drug is looking for and will bind to. If you cast your mind back and you think about ELISA and the antibodies and how antibodies target, specifically shaped illicit drugs from, I think, either lecture 1 or 2 that I gave, it's the same sort of thing. You have a very specialized chemical structure on the outside of the cell, and that will only lock a certain type of structural configuration in your drug. So it all comes down to the shape and functional groups of your drug and whether or not they match the receptors in this chemical species on the outside of the cell. Now, target molecules are distributed in characteristic locations in cells and tissues of the body. Basically, there are receptors where they need to be. They are usually on the outsides of cells, which means that once your drug crosses the first membrane from the circulatory system, so in the blood plasma, and they go into the interstitial fluid, which is surrounding the cells, from there, they are just looking at the outsides of the cells and they are looking for their receptor. If they don't find it, they'll continue their journey, they'll diffuse around the body until either the liver tracks them down, metabolizes them and kicks them out, or they find their receptor, they latch on, and then they do their thing. So, receptor theory. To produce a physiological effect, basically, you notice something happening, the following needs to occur. A drug needs to bind to a target molecule, forming a drug-receptor complex. So that is the binding event. It needs to happen, according to this theory, for something to occur. Now, that binding event must stimulate or inhibit the activity of the target molecule somehow or initiate signal transduction. So what that means is when there is a binding event, usually what happens is the conformation of the protein in the cell wall changes shape. And that could open up an enzyme within the cell. So it starts catalyzing a chemical reaction that way. Or, I don't know, it releases a chemical compound that was bound on the inside of the cell. There's a change of conformation and that compound is released and it goes and it finds something else to interact with. That's signal transduction, the domino effect. So the drug that binds the receptor is known as an agonist. It is the thing triggering the initial event. So here we just have a diagram of signal transduction. We have our receptor here on the outside. Here is our illicit drug. Comes in, it binds, on the outside of the cell. There is some sort of change in the receptor. Maybe it releases a chemical. Maybe some sort of catalytic site on the inside becomes active. And this produces additional reactions, secondary messages, which ultimately produces the response. So here we have reception, like you enter a building and you find a reception. Things happen, which is signal transduction. It delivers a response. So antagonists, drugs that bind the target molecule but do not change its activity. So over here we have our agonist. It comes in, it binds the receptor, changes the receptor somehow so that it does things. Now, you could have a different drug binds, it does not change the receptor, but it blocks anything else from binding. So you can think of an antagonist as a blocker. If an antagonist is present, it's going to be hogging the receptor. So your drug will come along, it won't be able to find the receptor because it's already full, and it will continue on its journey. So that's an antagonist. There are also partial agonists. Those impart a minimal physiological effect. So you might think of that in terms of you have like the perfect illicit drug. It finds the receptor and it causes a change. But you also have like a knockoff structural variant that was made, in some lab somewhere to get around the illegality. It's not quite a perfect fit for the receptor. It kind of fits, but it doesn't have the same physiological effect. That would be a partial agonist. Just to confuse things further, there are drugs that trigger the opposite effect to the agonist, and this is called a reverse agonist. It might be like, one drug binds and the cell goes forwards, but a different drug binds and the cell goes backwards. So that would be an agonist going forwards and a reverse agonist going backwards. Generally, cells don't move, but it's more a case of, I don't know, maybe it triggers the release of potassium, and the other one triggers the uptake of the cell by potassium. So, drug receptors, they have 4 defining characteristics. Firstly, they are specific, or they have specificity, which means that the drug can bind, but most others cannot. It is like looking for its match. The receptor has saturability, which means that the receptors are expressed in a finite or limited number, which means if there is too much of the drug around, all of it is going to become saturated. If you then added more drug into the system, it's not going to do very much, other than potentially overdose the person, because there are no more receptors for the drug to bind to. There is a set limit that, once they're all full, once the illicit drugs have found the receptors and bound them, there's no more receptors to find. The receptors have high affinity binding, which means that they are looking for the drugs that interact with them. That means they're going to be saturated at a very low concentration. So let's say there is a receptor, I don't know why, but it's in a bucket, and in the bucket there is like 300 different kinds of drugs, of which one is the drug that will bind the receptor. What that means is when that one drug finds the receptor, it will bind it tightly and to the exclusion of all others. And lastly is reversibility. So it cannot bind so tightly that it never, ever, ever lets it go. There should be no chemical bonds formed. It's going to be weak bonds like hydrogen bonding, which means that the drug and the receptor can bind together, but it can also leave. It has to be like that because otherwise you destroy the receptor as soon as the drug binds to it, and there's going to be no excretion pathway for that drug. It will essentially kill the cell if it does that. So there are 3 receptor theories where we talk about, trying to visualize how these events occur. One is occupancy theory, and this is the one we're going to focus on. We could talk about all 3, but it'll become confusing, and let's just do one. Do one and do it well. There is also, though, rate theory and 2-state theory. So know that while I'm going to teach you occupancy theory, there are 2 other theories, and they are valid in different ways. And all 3 theories have limitations, which is why there are multiple theories. Right, so occupancy theory, it's based on multiple assumptions. First is the law of mass action, which is the greater the concentration of the drug and the receptor, the more drug-receptor complexes are going to form. Common sense, right? All receptors for a specific drug are identical and equally accessible to the drug. That's a little bit less, I imagine, consistent with reality, shall we say. If we're thinking about our illicit drugs and the receptors are in the brain, but there's also receptors for, say, pain medication in other parts of the body, well, the receptors are probably not equally accessible, given in one case you have to cross the blood-brain barrier, but you don't in the other. But for the theory's sake, we are considering that accessibility is the same for all receptors. The effective concentration of the drug is not significantly reduced by drug-receptor complex formation. So basically there's going to be an excess of drug floating around, I would interpret that as. The intensity of the pharmacological effect is proportional to the percentage of receptors occupied. So let's imagine a system where there's 100 receptors. If 100 receptors are occupied, you'll get maximum pain negation, shall we say. If only 50% of the receptors are occupied, you'll only get around about half the pain negation. And if none are occupied, you get no pain negation at all. So, equilibrium constant, the KD, a specific equilibrium constant. We're going to use an example. We're looking at the drug cisplatin, shown here, and we're looking at a dissociation constant whereby here we have cisplatin. At some point, a chloride is getting displaced by water to give us this intermediate, and then it gets deprotonated. Let's not focus on this end bit, I don't think. We're only describing this step to simplify things. So what we are looking at is what's the amount of dissociation that we see when the concentration of these components is changed. So we have a concentration of cisplatin, we have a concentration of water, I guess in this case, and then we are forming, when we combine them together, we knock off the chloride, we get a concentration of our product at the end. So the dissociation constant equals the ligand concentration, and here the ligand is water. A ligand is basically any chemical species that coordinates to a metal. So here we have a chloride, a pair of chloride ligands, a pair of ammonia ligands, and over here we have a water ligand. If it's attached to a metal, it is a ligand. This is not a ligand, not a ligand, not a ligand, not a ligand. It needs to have this bonding event to the metal to be a ligand. Right, so we're only going to consider one ligand because this is an equilibrium at the end of the day. So here we have water attaching, so water becomes the ligand. But if we go this way, we have chloride attaching, and thus chloride becomes the ligand. We're only going to consider one ligand, either water or chloride, depending on what we're talking about. So dissociation constant, here we have another example, I guess. We're going to go back to the original one in a second, but we have nickel and we have 6 equivalents of ammonia. This can be in an equilibrium whereby the 6 ammonias coordinate to the metal to give you this complex. So here we have the ionic situation. We have nickel metal, or an atom of nickel, floating by itself. We have 6 equivalents of ammonia floating by itself. And then we have the complex, where we've got everything associated into one thing. So if we go back and we look at this formula, what we can do is we can plug these things in. So we have our, on this side at the top, we have our nickel and we have ammonia, and there's 6 of them. So we have to put the 6 up here, and then we form a complex. So this simply sits at the bottom. So that's the dissociation constant. This is, the constant for this to fall apart or dissociate to this. If we wanted to know the formation constant, which is whereby this comes together to form this, all we need to do is we need to swap the top with the bottom, and that would give us our constant of formation. But KD, that's generally all I'm going to be talking about. This is the constant of dissociation. And at this point you might be thinking, why are you talking about this? Well, this is all going to come back to donor-receptor theory. So if we think about, we could talk about the formation constant of a donor and a receptor coming together, or we could talk about the dissociation constant of a donor and a receptor coming apart. And we need to know this stuff because this tells us how strong our drug is going to bind our receptor. It's also going to tell us what ratio of our drug receptor complex is there going to be compared to the dissociated components. So is it mostly going to be associated, or is it mostly going to be fallen apart? So back here, we're still talking about our cisplatin. Just as like an aside, we've given now some concentrations. So we have a concentration for this one here. We have a concentration for H2O here, and we have a concentration for the H2O complex here. We're ignoring this one, and this one. Before we go into that though, therapeutic effect of cisplatin, it kills cancer cells. Side effect, it causes hearing loss. So just to go back to the really initial ideas, we can talk about those here as well. So if we're thinking about the dissociation constant, here we go. We have this side, so this one and this one. These are our not together component, shall we say, on the top. And we have our concentrations over here. And at the bottom, we have our everything is together over here. And our concentration is here. So we put this, plug it in, hit enter on our calculators. What we're going to discover is we get a dissociation constant of 0.15 molar. I believe this is the concentration whereby we have an equilibrium between the two. So what that means is if you have the ligand, say, so water, if water is in a concentration of this value, 0.15 molar of water, combined with cisplatin, it will form an equilibrium whereby half will be cisplatin, half will be in this constant. It's It's kind of like before we were talking about pKa. We sort of want to know where the equilibrium is sitting, because this will tell us when we have a good amount of receptor forming but also coming apart. That would be a good dosage of water in this scenario to aim for. Yeah, so this concentration, ligand concentration, is where M, this one, is equal to M plus the ligand, this one. So that's the ligand, no, that's the ligand, but this is where the ligand came from. So how might we experimentally determine this? We could do a titration whereby we are titrating metal into a solution of potential ligand. So here, in this case, let's try and do it for this example. Okay, so we are going to have a solution of 100% ligand. So it's going to be, I don't know, a volumetric flask full of water, and we're going to add to it our metal complex. And we're going to look at the change in the water. So before we add any complex at all, we have a pot full of water. So it is 100% ligand. And then we're going to start adding metal complex, and we're going to start to get some of our water taken up by the complex. And we're measuring and we're measuring and we're measuring. And eventually we're going to reach a point whereby it will start to saturate, saturate, saturate. And then finally we have 100% metal saturation. So we've seen graphs that look like this, you know, whenever we measure pH, for example. Same deal for here. If we look at this, we can, you know, very quickly do one of these calculations, and we can figure out with a 50% binding of our water, we have a concentration of, I don't know, what's that, 70 microliters. So by doing this experiment, we can experimentally calculate the dissociation constant that way. So what the dissociation constants mean? It's a way of showing how much a receptor likes to bind to your drug. Or in another way, it's affinity for the drug. If you have strong binding by an acceptor, I wonder if that should be receptor. No, strong binding by an acceptor, it's going to have a low dissociation constant. Basically meaning that when you get the binding event happening, it is not inclined to let it go. So that is strong binding. If you have a weak binding event, you're going to have a very high rate of dissociation. So it's kind of like bound very weakly. Most of the time, it's just going to fall apart pretty fast. So here we have a dissociation constant of 1.2 molar versus receptor 2, dissociation constant of 4.8 molar. Receptor 2, this one binds 4 times weaker than receptor 1. So the dissociation number is bigger, right? So because we're looking at the dissociation constant. So the fact that this is a big number means it is more inclined to dissociate, whereas this one is a smaller number, which means it's less inclined to dissociate. So this is why receptor 2 is weaker than receptor 1. If we were talking about the association constant, the Ka, it's really confusing to call it the Ka, isn't it? Because we've talked about different. This is why we're talking about the dissociation constant, to avoid this confusion. But if we were talking about the association constant, it would be reversed. A big association constant means it would be stronger versus weak binding event if the association constant was small. Right, so you can do this experimentally where you saturate the receptors and you find a 50% point. So here we have our drug concentration. We increase it. We can see it's not like a linear effect. But, you know, we obviously need to know what we're looking for in terms of seeing a 50% effect. If we're dealing with mice, it's very hard to tell them, do half of you still feel pain? But if it's some other physiological effect, you might be able to actually measure it, like high metabolism or something you could probably actually measure. Right, so this is a Lineweaver-Burke plot. If we have a look back, this has a rather strange shape to it. Kind of makes it a little bit hard to gauge this 50% point. This is called a saturation curve, by the way, whereby we go from 0 to 100%, so saturation, by just increasing our dosage to saturate all the receptors. And we're looking for 50% here. So this is where you plot 1 over the dosage to 1 over the effect, and then you get a nice linear plot. So down here, we need to backtrack a little for this one, and then we wind up with, which one are we looking for? Okay, so 50%, we're looking for the KD, which is here. 50%, we just measure it. Whereas in this one, we can see that the KD, you actually have to predict or go back in time. So, reverse plot minus the 0 point until you hit the x-axis. And this is going to be 1 over the KD. So this is the way you would calculate the KD. It's probably going to be more accurate because it is a linear plot. Someone's yelling outside my window versus this weird curved plot, which would be less accurate. Right, so a Lineweaver-Burke plot, it converts a hyperbolic saturation curve into a linear plot from which the value of KD can be much more easily extrapolated. So this is the backwards extrapolation I was trying to say but didn't have words for. As a reminder, KD is the dissociation constant of a reaction. Ooh, I've got 10 minutes to go, I think. I hope we're nearly done. This is commonly used to investigate the characteristics of donor-receptor interactions. So obviously if you aim for that 50%, that's the point whereby you have equilibrium. Half of it's in a binding event, half of it's been released, which would be a good characteristic of your drug to be in. It also shows the influence of competitive and non-competitive antagonists. Remember, an antagonist, that's where it's not your drug, but it binds the receptor and blocks your drug from having an effect on the donor-receptor complex formation. Right, so talking about antagonists a little bit, we have two types. There is competitive antagonists. So this is a reversible binding with your receptor. And what that means is that, let's say there is a competitive, so a reversible binding antagonist. If you increase the concentration of your drug just by natural competition of you having more drug, you are going to have the drug saturate the receptor. It will outcompete it. But a non-competitive antagonist, this is where effectively when the antagonist binds the receptor, it shuts it down irreversibly. So that means your drug is never going to work on the receptor. Doesn't matter how much of a dosage you provide. The receptor is closed. Right, so competitive antagonist, the additional block the effects of the drug because it hinders the binding. Adding more drug will offset the effect for a competitive antagonist. Adding an antagonist will offset the effects of a drug, so you can do it vice versa. So if someone's overdosing, for example, on an opioid, if you were to quickly administer a high concentration of an antagonist, you could knock out the opioid and effectively eliminate the overdose at that point. And that is what is done. So here we have a shift upon antagonist addition. Okay, so here is our dosage of drug and scenario A, B, and C. Scenario A, let's say there's no antagonist, so we need a relatively low dose of drug to get the effect. Scenario B, we have a bit of an antagonist present in the system, so we need a higher dose of the drug to see an effect because we've got this competition between the two. And then we have scenario C, where there is a high antagonist amount in the system, so you need a very high amount of drug to get the same effect you would see where the antagonist was not present. And you can see this in the Lineweaver-Burke plot. So here, it kind of looks like, so A is no antagonist, and then you get, this increase over on this side of dosage that you need to see the same thing. You'll note that the y-intercept is not affected. That means if you increase the concentration, your drug is still going to find a receptor and affect the effect that you want to see. Or to say another way, provided you provide enough drug with an antagonist even present, you will still have the same effect. You will eventually saturate all the receptors, provided you provide enough drug. Right, so non-competitive antagonists. Once your receptor gets bound by an antagonist, it's wiped out, it's gone. Increasing the drug concentration is not going to help at all. The maximum effect that the drug will deliver is also reduced because the number of binding sites has gone down. So yeah, think of these as the destroyers of binding sites, not competitors in an equilibrium. So the influence on the dissociation constant is minimal. And this is what that looks like. So as we increase our non-competitive antagonist, here is none. We see our normal effect. As we increase the antagonist, though, the actual effect goes down because we have less receptors, and we also need a higher dosage of drug as well. So more antagonists that are non-competitive go in, eventually you will see no effect whatsoever. And in the Lineweaver-Burke plot, you see this as a drop on the y-axis. Right, so just to briefly, no, we're not even going to do that. We're not going to touch on the other theories. You can look them up very briefly. I won't cover them in the exam at all. Skipping to state theory as well. So in summary, hopefully now you can define a therapeutic side and toxic effect. You can understand the effective versus a lethal dose and the implications that they have for the therapeutic index. Definitely take a look at that and know how to diagnose whether a safe drug versus an unsafe drug, or even rank which drugs are by safety. Should be able to tackle problems involving occupancy theory. That's the only one I talked about. And recognize the differences between agonists, antagonists, and how they relate to rate theory. That is it. I've spoken for 55 minutes, I think, which is perfect. Very good.